Thank you, and please, this is your time. I'll just say a few words as people are getting up, assuming that are you going to interact with these fabulous presentations. I just wanted to say a few words as you're doing that and just summarize a little bit that for Kevin, and there's so much that you could say about what you have to say, Kevin, just this idea that cost sharing is still somewhat, I don't want to say mysterious, but lots going on in the equation. And yet, Trace is saying, you know what? In the last 3 years, it seems to be making a difference. Those are the two connections that I made, that you didn't see that even a few years before that, but wow, what's going on? I don't know if it's the recession, or I'd love to hear more about other people's thoughts about why it does seem to be getting more, grabbing people more. And then, of course, Kelly, where do people go when nobody gets it? And it just seems that this social media is offering something that just wasn't there before. And boom, people are finding a vehicle to express themselves, and earlier presentations of using those stories as data, just connecting back to our previous discussion. So let me turn to those who are waiting to talk. I think Shoshana was up first.
No, I think Daniel.
Oh, were you? Okay.
He's such a gentleman.
Oh, yes, he is.
I'm concerned about the last speaker spoke also about incentives, but Teresa's telling us that word is a terrible word. The problem that I have, and I'm seeing it popping up in healthcare over and over again, is that we are incenting people, and this is for both patients and providers, who don't understand what they're being incented to do. They don't even know that there is an incentive there. It seems like this is another magical, I feel like it's magical thinking, what we sometimes do around incentives. And maybe it's because of what David said, is that if you don't have a feedback loop, the incentive isn't going to show. But I guess I would like to ask the panelists, all of them, what is it that we can do to use incentives effectively, as opposed to just use them and think of them as some kind of magic bullet? I mean, we did some focus groups to follow up on the focus groups I reported on earlier. And we had some presentations about, tiered provider tiering, right, where there were lower co-payments for some providers. People had no idea at all why there was a lower co-payment for some than others. Some very cynical people, oh yeah, I'm being pushed to that provider. We had one person say, well, maybe they're really trying to get those doctors more money, so that's why they're giving them a higher copay. So, I mean, the extent to which incentives are not understood, misunderstood, what does that mean about our ability to use them?
Well, I'll just say that, I think people understand incentives when it's explained to them.
Yes, but we often don't. We just put them out there.
You're right, and it's part of the big mystery of healthcare costs and why they're increasing, and people don't know, and I think we haven't explained it to the public. I think we're trying to find ways to do that, but yeah, I don't know.
But we're also have 5 different, right now, economic incentive-based value purchasing things going on in the Medicare program, all directed at the hospitals. I don't know how they can tell the difference. Well, with penalties and rewards and all that stuff.
Every system has underlying incentives. A lot of times they're not well communicated. I think on the patient side, it is really critical that we think about how to make these programs much, much simpler than they are, because it's just ridiculously complex, and I think very few people really understand the benefits. One of the things that we hope is that in the future we might have a far simpler world where you can imagine there's a constellation of high-value treatments, and all of those treatments should have no cost sharing. There's no reason for us to be putting cost barriers in the way of a diabetic patient taking their statin. It seems self-defeating. And what typically happens now is that a lot of times there isn't a lot of thought behind this. So there's a co-payment for a medication based on what the medication costs, and it has nothing to do with the value it provides. So if we had a much simpler system, you could imagine we'd have no cost sharing for a whole array of high-value treatments we actually want people to use, and then you could have much higher cost sharing for treatments that people probably shouldn't be using and which might actually harm them. But we're a long way from figuring that out.
Daniel Wolfson. So I have a comment and then a question. I wanted to just underscore what Teresa said about don't follow your instincts with messages. They're usually wrong. And we were going to call the campaign Stewardship Campaign. That was going to be our name. And we tested that out. And the physicians said, you mean like a union steward? Or you want me to steward all of society's resources? And as we learned from the research, as soon as you went beyond the patient-physician relationship and their well-being and the well-being of the patient, you can, as long as you talked about quality improvement of their patients, you were fine. You talked about an organization, and if you went to the society, you totally lost them. So it's really important. And I also just want to correct that you did select choosing wisely. At least half of it. And message, testing out messages is what we did, and the words really do make a big, big difference. So I have a question for you. As far as the incentives, are we talking about a difference between premium versus point of care costs? Is that what's maybe making a difference in what you're learning about cost now versus what Kevin is talking about? Because they're much different.
Yeah, I mean, I think where I'm really seeing it as is in the deductible. So paying, is that called point of care costs? I don't know the right language, but it's less about the premium. People are paying the premiums. It's more about having the high deductibles, and when they have to go, they're deciding, do I need this or do I not, and making those decisions because of the deductible.
Hi. Should I go? Yes, hi, Sally Oken from Patients Like Me. Very good conversation. I'm enjoying it a lot. I think to Teresa's point, vocabulary is so critically important. I communicate with patients a lot online, and a lot of times I have to be very, very careful and mindful of how I'm choosing the words, because the communication, first of all, is not face-to-face, and then second of all, there's always embedded messages within emails or other kinds of electronic messaging that you have to be so mindful and careful about. So I find myself getting more and more aware of that all the time. I wanted to follow up with Kelly, though. As a colleague in the social media space, I'm interested. You've actually quite obviously provided a way of being able to meet an unmet need for the population of patients that you're meeting with RA. I'm always wondering, because this is an area where we're always interested in, is there anything that you feel the social media space is not meeting at this stage that we could be doing better? And how might you just articulate that based on what your experiences have been?
Do you mean specifically for RA? What did you mean?
Well, that's your experience has been with RA. Obviously, you are gathering a lot of patients and their opinions, and you're talking with them a lot about the things that maybe they're not getting in the traditional sense, but they're getting a lot from having the opportunity to be able to complete surveys or just to connect online. And my worry is that even in our work, which we spend a lot of time doing user evaluations and doing persona-based design and trying to understand what is it that the users of social media really want to meet the needs that they have, I'm just wondering if there's anything among your population of patients that you've been working with that you've really felt like, gosh, I just wish we could do this, and it would make a difference for so many other people with RA in order to be able to meet an unmet need that they have, that social media still is not even meeting.
Right. I have a very long list of to do and projects for my own website, rawarrior.com. I've worked between 60 and 80 hours a week as a volunteer for 4 years. So I don't have enough time or staff to get done everything. So we created the nonprofit a couple of years ago, and we have a working board, and we have some volunteers and one staff, and we hope to be able to work harder, build that into a larger organization, and help patients to meet patients' needs through that, using the resource of patients and partnering together with organizations and government, and, as I said, with Mayo Clinic or with we'll work with anybody. We want to see these needs met. But I have to say, what you asked me is something that I'm asked 3 or 4 times a month. I get an email or a question. Can you please tell me what the unmet needs are? And I say, we're working very hard on meeting those.
Well,
So-
that's a great answer, and I think that we are trying really hard to do the same. It's a new place. It's a new place to do things, and so I think all of us who are in that space really need to be always
Right.
testing our assumptions that we're trying to meet the needs that people have out there. And so I'm just,
Right.
as a colleague.
I had to run past it because I was running short, but that slide about information and support with the 3 points under each, I'll go ahead and send you that too. I really think this is what drives patients, and these are the unmet needs. Whether it's confusion about what the researcher really is, or confusing research, conflicting research, about whether or not, a shot works better than an infusion, or how different is that than, a traditional DMARD, and there's conflicting research, but all kinds of questions like that are specific about information, to information about the treatments, to information about the disease.
Great.
The same kinds of questions.
Yeah.
I would imagine that would apply for other conditions.
Yeah, they do, and I think as a person who's trying to think forward and really be thinking, what can we be doing
Right.
in another year, 2, 3, or 4 years
Right.
with this new novel environment where we
Right.
actually are going to expand the abilities beyond what we can do today.
I think the
Like-
big difference is when people are looking for information in cooking and gardening and other things, it's the big difference between that and a condition, if you're a patient or you're caring for a patient, is that support part. That's what holds that together and creates that atmosphere where that information can be freely exchanged.
Thank you so much.
Thank you. And I just want to note, we're going to wrap up with the last people standing, and to try to make it as brisk as you can.
Funny how I seem to have triggered that.
Actually, I didn't even see you.
Started, could you it's okay. Kevin and Teresa, I want to say that last year, truly, my life was changed when I read Kahneman's book, Thinking Fast and Slow, and I came to understand the body of research that drives what you're talking about. I honestly don't think anybody can think about designing an intervention that's really going to change behavior without studying that field to the point where they really understand it. So thank you. Very, very important. I'm glad it came up here. I've known Kelly for a long time, and when she spoke, I heard things at a different level than the words that were coming out of her mouth. And what I saw was, I've got this thing about what are the nutrients that travel through the information circulatory system, and what drives that? And please, if you are at all interested in what a patient community can do, go study Kelly's blog, because this is not an ordinary blog. I do blogging where I spout my mouth. She has so many links and resources, and it's a technically incredible website. And the thing that occurred to me, this morning we heard about Marshall Gann saying distributed leadership, right? And we have this issue of, if we can't get change through the establishment, how do we get it to where it needs to be? Well, how about we go through sort of the underground railroad of information, going directly to the people whose lives are at stake? And what I've seen over the last couple of years on Kelly's blog, if we want change, it's really worth studying this. What's going on there that causes these supposedly slacker consumers who we can't get to change behavior to step up and be hungry for information and share with each what's going on here that's different than the paradigm? Thanks.
Absolutely.
I'll be as brisk as Dave. That was not meant to be a threat. Not really. One aspect I'm resonating with Kelly's presentation in relation to the outcomes that we measure and that we incent or promote in pay for performance or other strategies that are, doomed to my point of view, but it still exist. And the quality of life and patient-reported outcomes story is very interesting. But one outcome that I would like particularly the patient communities in the room to start paying more attention to is the notion of burden of treatment. There's a lot of discussion out there about burden of illness and how it affects your ability to function. Right. But we in the case of patients particularly that accumulate multiple chronic conditions, the burden of treatment plays a huge role in impairing people's ability to perform and to live lives that are spontaneous. And so there's a notion out there of a new kind of medicine that tries to reduce the burden of treatment in patients' life alongside pursuing patient goals, and that's called minimally disruptive medicine. And so I want the patient community in the room to be more attuned to this and to begin to advocate for, alongside measures of quality of life, measures of burden of treatment.
Hi, I'm Kristen Lind, and I was the one who stood up yesterday and talked about my concern about culture eating strategy for lunch. And so I've been thinking about that as we've gone through the last day and a half, and I was really happy to hear you, Kelly, talk, because I think you kind of raised something that I as a mom who for many years wasn't activated and wasn't engaged, but then suddenly was. And I'm very curious about how something like that could happen. How could somebody as unengaged as I was be standing here in this room today? And as we think about partnering with patients and engagement and activation and trust and cultural competence, I think that there's also a very special role for patients and families as representatives in the healthcare system to be a bridge, to be a liaison between medicine and patients. And I think, I hope that I'm articulating this well, but I'm going to try to wrap it up. But whether it's as family and patient partners on QI teams or through patient and family navigators or liaisons, I think that as we think about trying to build a pathway towards partnership, we think about what is a very specific role that people with lived experience can play in bridging this partnership, which has a lot of cultural obstacles to it. So thank you so much.
Thank you.
I'm Bob Rohr. One of the problems I have with, everyone likes value, but so often in the past, value has been defined as value to the healthcare system or to someone else, not necessarily to the patient. And when it has been defined as values to the patient, it has been defined by according to data and generally according to the mean or the average. So it doesn't deal very well with the outliers, the people who don't respond well to drug A, but do respond to drug B, even though it's the secondary one with higher copays or whatever else. It also the system doesn't respond very well to different values of the patient in terms of what they're seeking, whether it is relief from certain symptoms, better functionality, quality of life versus quantity of life, things like this. So I think we have to start thinking of value as being very individualized to the health plan of the patient based upon their desires and what works for them, and not simply fall back into what's easiest for the system, which is a bunch of numbers.
I think it's a really important point, and I see this as one of the big challenges to implementing recommendations like the Choosing Wisely initiative, because in essence, as you said, there is a heterogeneity of treatment effect, and so on average, a service may be extremely low value, but there's going to be some portion of people for whom it might be at least moderately high value. And figuring out how to come up with defensible and simple rules that, for example, a health plan could use to adjudicate who gets this covered and who doesn't is actually very complicated. We've had a number of discussions with health plans about trying to do that, and it becomes a stumbling block very quickly. So somehow we have to figure this out. I don't think it's a reason not to proceed to help the, let's say, 95% or 90% or 80%, whatever it is, of people for whom it's low value, but it is a big challenge to figure out.
Thank you. Barbara Kornblau, the Society for Participatory Medicine. I just wanted to give kudos to Kelly. I have arthritis, and I worked with a lot of arthritis support groups in the Miami area. And what we did is if someone called the Arthritis Foundation and they were diagnosed with RA, they were immediately referred to one of my friends, Linda, who's had 31 joint replacements. And she would give them the introduction, and help them through the system. So I just want to stress that power of patience again. And one additional point, and that is on quality of life. You know, we measure quality of life. Providers will often ask people, you know, how much sleep do you get? Are you taking your meds? You know, all those standard questions. And one of the studies that I worked on in my occupational therapy hat looked at a concept called occupational autonomy. And it was very simple. It was being able to choose to do the occupations or things that are meaningful and purposeful to you when you wanted to do them. The things, to be able to do the things you wanted to do when you wanted to do them. And we call that quality of life. And I think it's very important to ask the patient when you have chronic pain, when you have days when you can do things and can't do things, to just say, what do you want to be able to do? What's your goal? What can't you do now that you want to be able to do? Let's work towards that.
Please join me in congratulating them.